Alhamdulillah. All Arabic speakers, or we have English speakers? English speakers. So we're supposed to say the lecture in English, right? It's okay, no problem. Sometimes I will need to clarify something in Arabic, but I will translate everything. So if I say something in Arabic, I will be sure that I will translate. Everything is in English, no problem. So, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Mahmoud Abul Majd, the head nurse of the ICU. And today we will talk about the care of ventilated patient. But first, I'll just give you some background about the ventilator itself. I wish if I can bring a ventilator down from the ICU to show you everything, but it's okay. We will have some photos and explanation about everything. So first of all, let us talk about our outlines. Definition of mechanical ventilator, indications of mechanical ventilation and modes, classification of mechanical ventilators, complications, and then at the end, the weaning and the nursing intervention. This is what we will talk about. First of all, what is the definition of mechanical ventilation, and why we need to invent something like the mechanical ventilator? You know, sometimes we have many problems in some patients, like some problems regarding the airway, how to protect our airway, and some problems regarding the breathing. And we have other problems related to the gas exchange or the function of the lung itself. So according to all this, it's a must to have a device that can ease this process. So it's the supportive therapy, and this is very important to know. It's only a supportive therapy. If your lung is not working well, the ventilator can only support but cannot do the gas exchange. So we will know now the difference between respiration and ventilation. But in the beginning, it's a supportive therapy used to assist patients who are unable to maintain adequate oxygenation or carbon dioxide elimination. So it will support only the gas exchange process. It will not do the gas exchange process. But we have other devices that can do this, such as, do you know any other device that can do the gas exchange for us? Do you know the heart-lung machine? ECMO? Yes, very good. The ECMO. We have the ECMO which can make the gas exchange for us. The extracorporeal membrane oxygenation. This is a device that can be used for the patients who has ARDS. So we can activate it to make the gas exchange process, but not only a supportive therapy. But the ventilator is only a supportive therapy. So let us say what is the difference between ventilation and respiration, and this is a very main concept that we should know, all of us. So ventilation is the process by which fresh gas moves in and out of the lung. This is the issue. So the ventilator will do this process only, not the gas exchange. It can support the lung to move the air from outside to inside and from inside to outside through three main parameters. The ventilator can control the flow of air and the pressure of air inside the lung, and also the volume of air that can enter the lung. So these three criteria, the ventilator can manage it all the time. This is the issue, but not the respiration, which is the transport of oxygen from the outside air to the cells within tissues. This is the function of the lung, not the ventilator. Ventilator can support this function, but cannot do this function. ECMO can do this function. So anyway, now the main concept is that the ventilator is to move the air from outside to inside and from inside to outside through moving flow or controlling flow, volume, and pressure. This is the issue. So what are goals of mechanical ventilation? So as you know, we have many goals of mechanical ventilation. According to what we have said, to get oxygen into lungs and body, it's by support only. It will not do this, but by support. And can control, by the way, the amount of oxygen that move from the outside to inside. Because as you know, all the normal air, we have 21% only is oxygen, right? The percentage of oxygen in the normal air is 21%. But the ventilator can make it better than this, can make it more than this, until 100% oxygen even. So to help the lungs to get rid of carbon dioxide, also with the main supportive process, to ease the work of breathing, and this is very important. Some patients, they don't have the problem in the lung itself, but like the patient of Guillain-Barré or myasthenia gravis, all these kind of diseases, they have problem with the muscles itself. All the very old age patient or the trauma patient, so these kind of patients, they have like a problem with the muscles of the chest and the ribs, so they cannot do the work of breathing. So the problem is not the lung itself. To breathe for a patient who is not breathing because of brain damage, injury like coma, high spinal cord injury, like this. So also these patients, the ventilator can support them. Anyway, now to talk about the indications. We will categorize everything into 3 categories. Number 1, the problem with the airway. Number 2, problem with breathing. And number 3, problem with the gas exchange. These are the main categories of the indications, of the problems that indicate using the ventilator. But let us just discuss with each other. Anybody knows what kind of indications related to airway if we have these kind of problem? Any problem with the airway or breathing? Very good. If we have any enlargement in some kind of organs here like thyroid or whatever, anything can block the airway, you mean. This is number 1. Any other thing? Breathing, gas exchange. What kind of diseases?
COPD.
For sure, COPD patient. Like these kind of patient has problem with the gas exchange process. Also the RDS, right? Acute respiratory distress syndrome. What about breathing? If myasthenia gravis, for sure. Guillain-Barré. It's the same. That kind of patient, he cannot move his chest muscles because he has problem with the muscles of all the body. Anyway, so these are some examples. So I need you just to categorize with me. I will tell you the indication and you just tell me if it's airway, breathing, gas exchange. So what about inability to protect patient airway? Airway for sure, like the trauma patient, like the unconscious patient. Unconscious patient cannot protect his airway, right? We have one of the rules in the ICU said GCS below 8, intubate. GCS below 8, intubate. If you have Glasgow Coma Scale below 8, so you should intubate the patient. 7 and down, like this, you should intubate the patient because this kind of conscious level, the patient cannot protect the airway. And then hypoxemic respiratory failure, okay? Like PaO2 less than 50. What is the normal range for PaO2, by the way, in the arterial blood gases? It's from 80 to 100. 80 to 100, but less than 50, this is very severe hypoxemia. So we have problem now in the gas exchange, right? Hypercapnic respiratory failure, it's the same. Now, we have 2 types of respiratory failure type 1, respiratory failure type 2. Respiratory failure type 1, we have hypoxia, okay? And respiratory failure type 2, we have hypoxia and hypercapnia. Type 2, we have hypercapnia more than 50, okay? The normal range of the CO2, it's from 35 to 45, very good. But more than 50, this is the problem. Let's just tell you a piece of information outside what we are saying. We have some patients, we have problem with the lung, like the COPD or something. We can give them permission to have COPD, to have CO2 until 50, but not more than 50. It's called permissive hypercapnia. Permissive, that you give the permission for this patient because he's a chronic patient to reach until 50 only in the CO2, but no more than this. More than this, we have a problem. So more than 50, that's why I just say that, just to understand why we choose more than 50, why the normal range is from 35 to 45, okay? So this is what's called permissive hypercapnia in some patients, to give them the permission to reach 50, no problem, but not more than 50, because he is a chronic patient or something. So persistent respiratory acidosis, this is a big problem. If we have increased CO2, we will have problem with the pH, we will have acidosis, pH will go down. So now if the patient has severe acidosis, respiratory acidosis, we can use also the ventilator to wash the CO2. Yes, to wash the CO2 and return the pH back to the normal. Acute respiratory distress syndrome, chronic obstructive pulmonary disease. This is problem with airway, breathing, gas exchange. Gas exchange for sure. And also thoracic or abdominal surgery like drug overdose, something like this. After surgery or during surgery, during sedation, all the time we will need to make the patient on ventilator because it's induced coma, You will put the patient on coma induced by your medication. That's why you should do this. Also, what kind of category is this? Airway or breathing? And airway also, because the coma patient cannot protect the airway. If the patient has like vomiting or something, it will go back to the airway and it will block the airway. Neuromuscular disorders, for sure. This is about airway or breathing. Breathing. because if the patient has neuromuscular problems, so muscles of the chest cannot make the work of breathing. So these kind of indications of the ventilator. It's not all the examples, but it's just the main categories of the problems. So now we have two types of ventilators. The two types of ventilators, one is old-fashioned and we don't use it these days, and the other one is the most common that we have in our hospital. The old one is the negative pressure. This is the negative pressure ventilator. It's called the iron lung. They invented it since 1929. It's very old, and they used it until maybe 70s or something. It's the negative pressure. The patient goes inside this iron tube and only the head is out. It's working through the negative pressure. If there is negative pressure inside, so it will make the patient like have a ventilation like this, and then to make it positive, so the muscle of the chest will compress the chest. It's a little bit old-fashioned, as I say. The new one is already the positive pressure that we have in our hospital. This one, okay. And by the way, this one is a little bit old. We have very new now in our hospital here. We have a very sophisticated ventilators. It's very advanced, better than this one. So this is to apply positive pressure to the airway and lungs through the use of an invasive airway and sometimes non-invasive. And you can use it with the BiPAP, like the BiPAP mask, and sometimes you can use it through endotracheal tube. Both of them is good. This is the shape of our endotracheal tube and also the connection for the ventilator. Connection is the Y tube. It's called Y tube because it's the shape of the Y letter. So it's Y tube. You have one for inspiration, one for expiration. This one will goes to the patient like this. And the two connections will go, one for the inspiration, one for expiration in the ventilator. So about the ventilator settings, it's very important to know the ventilator settings. Just it will ease understanding of the modes, because modes are very complicated. By the way, it's not. I'll just tell you the basic modes, but we have too much modes. I will just in this lecture we will talk about only the basic modes that we can use in the ICU. Anyway. These kind of settings, you should know it to understand the modes. So first one is the respiratory rate. It's very easy. It's like the how many breaths that the patient will take in 1 minute. So you can put it between 12 to 24 according to the case of the patient. And let me ask you a question in this part. If you have a patient with high CO2, like patient with hypercapnia, in your imagination, which kind of the respiratory rate that can we put? High respiratory rate or low respiratory rate? Can we put in 12 or 24? 24, right? Why? Just to have the patient wash the CO2. And also we can use other parameters like this to help washing CO2. Anyway, so this is the first one. According to the case of the patient, we can choose which kind of respiratory rate that we can use for this patient. Second, tidal volume. This is very important parameter. Tidal volume means the volume of the air that you will, that will enter the lung in one breath. So each breath, your lung can stand some amount of air, and it's different between every one of us. Let us just say if I have a man that is very tall, he is 2 meters height, okay, and he is a bodybuilder. So the same amount of oxygen or the same amount of air like me, I am, anyway, so his body will need more air, more oxygen than me because of the muscle mass and everything. So anyway, so we are talking about according to every one of us. But we have like normal range according to the weight. So usually it's from 6 to 8 cc per kg. So if I have somebody with 100 kilograms weight, so from 600 to 800 cc, this is the normal range. Also according to the case, if we have a patient with like the ARDS patient has like stiffed lung. The lung is very stiffed, so he has a very high risk to lung rupture. So I should not give him high volume. But in the COPD, we have high lung compliance. Compliance means that the lung can extend, you know. So the COPD patient, normally it's pathological wise, yani. Pathophysiology of the COPD is like that. It gives the lung the high compliance, so the lung can extend more. So I can give a high volume for a COPD patient, unlike the ARDS. So according to the case of the patient, we can give a volume, and also according to the body mass, you know, according to the weight. Then fractional inspired oxygen, FiO2. The FiO2, it means the percentage of the oxygen that you will give for the patient. Like as I said before, we have the normal percentage of oxygen in the normal room air. It's like 20 to 21%, right? But you can increase it according to the patient. And we have, a formula that can count this. But it's not our topic today. But anyway, you can count by kind of formula to know which FiO2 is good for the patient. Anyway, you can know. Normally you will extract ABG, right? And you will see the PaO2. And according to the PaO2 and the oxygen saturation on the monitor, you can raise or make it down according to the FiO2, according to the PaO2 and the oxygen saturation, right? So anyway, this is the fractional inspired oxygen. Inspiratory expiratory ratio, this is very important. You must understand this because this is very important parameter. It's the time of inspiration to the time of expiration, the relation between them, like how much the time of inspiration, how much time of expiration. And it's very important because you can give the lung the time to make the gas exchange. You know, the normal lung is different than the diseased lung. The diseased lung, or the lung with abnormal lung, it's not very, you know, it's not functioning well. So you should give it a little bit time more to make the gas exchange. So if I have a hypercapnic patient and I want to wash CO2, we have two parameters very important to know it, to manipulate with them until you have to support the lung to expel the CO2. First one is the respiratory rate, as we said, and also the I-A ratio. I can increase the I-A ratio, like to make the patient make an inspiration in a small time and extend a little bit the time of expiration, just to keep the air inside a little bit more time, so the lung can make the gas exchange, yes, a little bit. So you give the lung the chance to make it, because it's abnormal lung, it's not normal lung. So anyway, this is very important parameter also. It can be 1 to 2. I mean, if I make, let us count with each other. If we have the patient, like, you will put, I will just give you an example to make it easy a little bit. If I put the respiratory rate 10 breaths per minute. 10 is very low, I know, but just to ease the calculation, 10 per minute. So what, how much the time of every breath? If I have 10 breaths per minute, how much the time for one breath? You can count 60 over 10, so it will give you 6 seconds, right? Yeah. So every one breath, every respiratory cycle, you will have 6 seconds, right? So if I make it 1 to 2, so the time of inspiration is half the time of expiration. So I will have inspiration in 2 seconds and expiration in 4 seconds. All the cycle is 6 seconds, as we said. All the breath. The breath consists of 2 things, inspiration, expiration. So if I will make it 1 to 2, so the ventilator will give the patient 2 seconds inspiration and it will give 4 seconds for expiration. So the patient will do like this. You see? So inspiration is very fast, but expiration is a little bit long, just to give the chance for the lung to make gas exchange. This is the I-A ratio. This is very important to know. Also, we have here what's called the pressure limit. As I said before, the 3 main criteria that you should know about the ventilator, and it's controlled by the ventilator, is first the flow, airflow, and also the pressure and the volume. Now we are talking about the pressure. We talked about volume in the tidal volume, and now we're talking about the pressure limit. So take care of the pressure, because if you have a patient, as I said, with ARDS, and this kind of patient has a little bit high lung elastance, I mean lung elastance, it's very stiff. It can be ruptured or has what's called parotrauma, as we will talk about in the complications. So you should take care about the pressure. Do not make high pressure for this kind of patient. So like the balloon, if you will, inflate a balloon, if you give a high pressure, the balloon will rupture. It's the same as the lung. So the normal pressure is 2 to 10 H2 centimeter H2O. This is the unit above peak inspiratory pressure. I mean, totally, it will not come more than 35. Okay, so it will not come more than 35. The peak expiratory pressure, we will talk about it in the PEEP. Okay, it means that the amount of pressure that will stay in the lung after the expiration. Like this time, you have pressure inside. This kind of pressure, if you put above it with the new inspired oxygen, will get it more, more pressure. It will reach at the end 35. So I mean, the lung will move like this. It will inflate and deflate like this, not like this. Normally, if you have complete deflation, you will suffer something called atelectasis. Atelectasis, it means that totally it's a lung collapse. Yes, you don't want this collapse to happen, and normally we don't have collapsed lung. Normally we breathe like this until here only, and the heart is the same. Heart is moving like this, not until the end. So it's the same. So you have at the end, some air will stay in the lung, in the alveoli at the end, just to give you the very small amount of pressure to prevent the lung collapse. This is what's called PEEP, positive end expiratory pressure. So it's the pressure at the end of expiration. And this is what we will add above it, the new pressure of the new inspired breath. It will give you like 20, and this one, it will give you at the end maximum of 35. So now you get the relation between both two. Any questions for this? So the PEEP, it's positive end expiratory pressure. This is normal, this is physiological. Every one of us has PEEP, normally. And the ventilator also should do this to prevent lung collapse. So the PEEP, it's normally from 5 to 20 maximum. I never see the 20. All the time we make it 5, 8, maximum down. In the COVID patients or somebody that you want to support the gas exchange, maybe 10. More than normally we don't use more than 10. I'm talking about my experience, the most common. But it can reach to this, okay? Then the minute ventilation, the last parameter, the minute ventilation. It's like the tidal volume times the respiratory rate. I mean all the volume of the inspired air in 1 minute. So the tidal volume, it's all the amount of air in one breath. Minute ventilation is all the amount of air in 1 minute. Okay, so it will be tidal volume times the respiratory rate, because tidal volume is one breath, respiratory rate is all the breaths in minute, so it can give you the minute ventilation. Anyway, so now all the parameters. Any questions in the parameters? Any questions? So normally you should know this, just to manipulate with the ventilator and change it according to the case of the patient. Ventilator modes, as you see, they are too much, but I will not explain everything, because it's very advanced and sophisticated. These days we have, by the way, these modes, we have more than this in some devices, like the Hamilton in our hospital. It has some modes more than this, because Hamilton is very advanced. It has like it's a adjusting mode, like it can adjust itself with the patient according to the case. But this is very sophisticated. We will not talk about this. Well, I will just explain the basic modes that can make you understand. You have understanding for all the modes a little bit, okay? And these are the most common modes that I will explain. Anyway, I just showed you this slide just to know that we have many modes. So let us talk about the first mode here. It's what's called controlled mode, or the CMV. Controlled or the CMV. This kind of mode, as you see here, this is the airway pressure, okay, and this is the time. So you will have like peak pressure, which is fixed, and fixed time. Fixed pressure, fixed time. It means that the patient has no any support. has no any sharing. The patient never share in this process. The ventilator will do all the work. It means when you give the patient sedation and muscle relaxant, some medications like succinylcholine or atrachium or recronium, these kind of medications that can make neuromuscular blockage or that can make total muscle relaxation, so the patient has zero effort in breathing. The ventilator will do everything. Okay, so this is in deep coma, or if you give muscle relaxant, you can put the patient on the CMV. The ventilator will do all the work. Time cycled mode with fixed pressure, fixed volume, everything. The patient will not share, zero sharing. So this is the first mode. Second mode, here we have what's called AC, assist control. Assist control, the first one is control. So totally the ventilator is taking the lead to do everything. But now we have assist control. So the patient will begin to share something. But we have here, you have a target. So you tell the ventilator that I need 16 respiratory cycles, okay? And I need specific pressure. I need specific volume, everything. You give him everything, and this is the target. We will reach this target, obligatory, over the will of the patient. So anyway, the patient, if tried to share, if the patient, you see here, if we go through this is the pressure, no negative pressure. Negative pressure means that the patient tried to inspire air. This is negative pressure, but this is the pressure limit, no negative pressure. It's positive pressure only, so this is the work of the ventilator. But here, if you check, there is inspiration effort. The patient is trying to do something, but it's a little bit very low, a very weak trial, but it's okay. The patient is trying. And at the moment he tried, the ventilator supports. The moment he tried, the ventilator supported. Okay? But here the patient is very weak, so he cannot do anything more. The ventilator will give. So it's time cycled mode. I mean time cycled, it's fixed time of the respiratory cycles. But it allows the patient, if the patient tried, it will support. If not trying, it will give. This is assessed control. For this one, it's called SIMV, synchronized intermittent mandatory ventilation. Synchronized intermittent. Let us just analyze these words. Synchronized, it means that it's synchronized a little bit with the work of the patient. So it will give the patient the ability to trigger the vent. Trigger the vent is to try to have a respiration. So the patient will begin like this, and the ventilator, and this is the difference between this one and the last one, the previous one. We have here the SIMV. The patient is trying himself, and the ventilator will keep him alone trying. It will not support him. Leave him just try to train the patient. He's doing training like this. So triggering, another triggering. You see, it's a very weak effort of breathing for the patient. It cannot make it like this. And on a specific time, the ventilator will give the breath. And then again, a little bit trial, another trial, then the ventilator will give totally. So it's a time cycled, it's synchronized, that it will try to synchronize him with the patient. It will leave the patient try between the breathing cycle and another breathing cycle. It will give the patient the chance to try. But on a specific time, it will give a complete breath. It's a mandatory also. So it's synchronized intermittent, but it's mandatory at the end. It will not let the patient try all the time. Okay, so it has a target, it will reach it. If the patient has no any trial, it's okay. It will give him the breathe, because it's mandatory at the end. Okay, so the difference here between this one and the assist control is that the assist control, at the moment the patient is try, the ventilator will support. But here it will give him the time to try himself alone totally, then will give him the support on a specific fixed time. Okay, so this is the SIMV. Now we are talking about another ventilation, and here we can start to call these modes as the weaning modes. So we have a good patient who can trigger the ventilator, and he needs a little support, a little pressure support. Like he is good, we can wean from the ventilator now, but we are trying to wean gradually. So we will give him a small support, then we will remove the ventilator. So now starting this one, we can call it a weaning mode. So PSV, the first one of the weaning modes. The PSV is the pressure support ventilation. What is the pressure support ventilation? From its name, we have a specific pressure that the patient should reach. So I will give the patient the chance to make an inspiration. And then my target is to let the patient reach 25 centimeter H2O. So the patient can only reach the 20. So I will support with 5. The next breath, the patient can reach to 15. So I will support with 10. So like this. It's anyway pressure support only. I will let the patient try himself. I will just reach the target of pressure. This is the issue. But I will not give unless the patient take a breath. Let us see the PSV here. This is the shape of the ventilator. You will see this kind. So if you take, just notice this, we have here the same pressure. Okay? The same pressure. It's at the same point. So every time the ventilator will give him, will let the patient reach 25. If you put it 25, it will reach 25 every time. Either the patient take it himself, or the ventilator supports. At the end, it will reach 25 centimeter water. But if you notice here, it's not time cycled. I mean, there is no fixed time. So it will wait until the patient try to take the breath himself. The patient takes a breath here and he supports. And then the patient stopped. Then the patient tried here and then stopped. Then, you know, so it's not time fixed. I mean, time cycled, it means fixed time. Here it's not fixed time. It's according to the patient. So can you put this mode on a patient on a deep coma?
No.
You can't. Can you put this mode on a patient on sedation, severe sedation? You can't. Every time you need the patient to be awake and can trigger the inspiration himself. Okay? Here we have the CPAP mode. It's the continuous positive airway pressure. It's the mode of choice for the weaning. Mode of choice. All the time we wean the patients on this CPAP or BiPAP or like this. So the CPAP, now we have continuous level of elevated pressure is provided through patient circuit to maintain adequate oxygenation. So we have a good patient who can do the effort of breathing, but there is a specific difference here. You see, here the patient is trying to take the pressure and we have specific pressure. The ventilator will give this pressure until the patient reach the peak pressure. There is a small difference between CPAP and PSV. The small difference is that the PSV, it's only pressure support. It means, you know, let me just give you an example. If I will just move this object like this, I will have a specific effort. But if you are from the other side, try to push a little. So my effort will be less, right? This is the PSV. It will give you an environment of high pressure. So your trial is good, is easy for you. But the CPAP is not like that. CPAP is waiting for you until you take the breath, and it will give it until a specific pressure, like high pressure and release, high pressure and release, high pressure and release, like this. But the PSV, no, it will give you like high pressure to ease your work of breathing, not like CPAP. CPAP will wait until you take the breath, and then it will give you, make it to reach the specific pressure that you give. So it's, you know, a very small difference between CPAP and PSV. Most of the time we use CPAP, by the way, not PSV. In our ICU, most common, we use CPAP for weaning anyway. So this is the issue. We have here trial for the patient, you see? Trial. This is the negative pressure, this is the trial of inspiration. And then it will reach until the peak at once. At once the trial, the vent will give him the peak, like this. Okay? BiPAP, it's the same CPAP, but with a little, you know, addition. We add a small feature, which is, in the CPAP we have continuous positive airway pressure. Here we have bi-level airway pressure. It means in the CPAP we give him the high pressure only, but here we give high and low, high and low. Like we will support in inspiration and expiration, but in CPAP we support in inspiration only. You see, we support in inspiration and then release. But here, you give him high pressure and positive index expiratory pressure, like PEEP. The low pressure is the PEEP, by the way. Remember the PEEP? It's the lowest pressure after expiration. So the ventilator will support him both. Give him like high pressure, low pressure, in a time cycled manner. It will not allow the patient to trigger the breath, unlike the CPAP. CPAP, the patient should trigger the breath, should begin the breath. If the patient did not begin, it will not continue. It will give you alarm, but it will not give the patient alone. So we have what's called a plan B, you know. In CPAP, if the patient did not trigger the breath, the ventilator will not give a breath. But after a specific time you put on the settings, the ventilator will give you alarm that the patient did not make any effort of breathing. This is a very bad thing. So it will turn automatically to a mandatory mode. So again, in CPAP, there is much difference between CPAP and BiPAP. BiPAP, we have support in inspiration and expiration. CPAP is only in inspiration. So CPAP will make it until a high pressure only and then release the patient totally to make the expiration. But here, bi-level, it's like inspiration, expiration, inspiration, expiration by the ventilator. And also, we have a very important thing. In CPAP, the ventilator will wait for the patient to trigger the breath. But here, no. It will not wait. It will give mandatory high pressure, low pressure, high pressure, low pressure. And between them, the patient can trigger some, you see these things, these waves are the triggering of the patient. The patient is trying to breathe. But the vent is giving. So the BiPAP is a little bit mandatory. Unlike the CPAP. CPAP is totally depends on the patient. So CPAP is the mode of weaning. The mode of choice for weaning. Okay? Any question in the modes? So we talked about CMV or the control mode. It's totally the patient dependent on the ventilator without any effort of breathing. And then the assessed control, we have a little bit trial from the patient, and if the patient tried, the ventilator will support. If not, the ventilator will give already. It's IMV, the ventilator will try to synchronize itself with the patient. So when the patient triggers, the ventilator will not give anything. We'll give him the full trial, and then after that, give the full breath. Then PSV CPAP, it's a little bit similar, but with a small difference. We're talking about the CPAP, which is the most common here. It's the high pressure and then to release. Specific high pressure and release. But here, it's high pressure, low pressure in the BiPAP. Any questions? These are the basic modes. Now we are talking about a very important topic. So until this time, I talked about the definition of ventilation, difference between respiration and ventilation. We talked about the goals, indications, parameters, and modes. Starting now, we will talk about the alarms, and then after that complications, and then the nursing care. احنا طبعا بدأنا متأخر شوية، فمعلش الساعة جت 12 ولسه ما خلصتش. انا كنت عامل حسابي على ساعة بالظبط، فاحنا بادئين ونص تقريبا، فغالبا كده يعني مش عارف هيبقى في وقت. انتوا المفروض يعني انا كده كنت عامل حسابي محاضرة ساعة، فمن 11 ونص ل 12 ونص هيبقى في مشكلة عندكم في عادي؟ خلاص احنا نقعد بقى لحد الساعة 2 مفيش مشكلة. خلاص ان شاء الله نص ساعة بالظبط ونكون خلصنا. Alarms, it's very important to know the alarm of any device in the ICU. It's not only the ventilator or any area, by the way. In all the hospital, you should know all the alarms of the devices, like the monitor, like the syringe pump, infusion pump, everything. You should know, because this is the trouble, and you should know the troubleshooting, what to do if you just see this alarm. And the ventilator, as it's it's a life-saving device, because you are talking about airway and breathing. So this is like we have a rule that says, treat first what kills first, and airway is the first killer for any one of us. So you should take care. This is airway and breathing. So alarms, you should know alarms very well. Number one, you can see sometimes high pressure alarm, and let me just ask you, if you see high pressure alarm, what can you expect in the patient? High pressure. Patient is trying to trigger. Sure, if the patient is fighting the ventilator, you can see high pressure. What else? What about? What?
I think disconnected.
Disconnected did the high pressure or low pressure? أيوة. الهاي بريشر there is resistance. Kinking for sure طبعا. If there is kinking in the connection, you can see high pressure. What about secretions? Heavy secretions. So there is blockage. The ventilator is trying to push, but something resists this. This is what's called the high pressure. So secretions, kink in the vent tubing, patient biting on the ATT. Sometimes, most of time we put oropharyngeal airway beside the tube just to avoid biting on the tube. And also patient coughing, trying to talk, trying to fight the vent, increase the airway pressure from bronchospasm or pneumothorax. Yes, sometimes if the patient has pneumohemothorax like this, so it increases the intrathoracic pressure and it causes resistance. It's the same. So low pressure, as you said, if we have disconnected tubes, so disconnected tubes can give you low pressure. So ventilated tubing not connected, it will give you low pressure. Displace the ATT, this is very important. So if you see low pressure, just run to the patient and check what kind of problem. High respiratory rate, sometimes you may have pain, the patient has pain or anxiety or something. Psychological trauma, by the way, is one of the most important complications for the ventilation. Anyway, also secretions in the ATT, hypoxia, hypercapnia. If the patient has any problem that makes him trying to breathe faster. So also low exhaled volume, this is very important. Low exhaled volume, it means that the ventilator senses that it gives some amount of air and half of this amount goes out. So we have we have hole, we have problem. If the expelled air should be the same amount of inspired air. But now maybe ventilated tubing also is not connected. Leak in the cuff, endotracheal tube has a cuff here to seal, to make a good sealing for the endotracheal tube, around the endotracheal tube here, in the endotracheal tube. So you should take care there is any kind of leakage. If it's not inflated, you will have leakage. So it's the same. So if you see this one, just check the cuff, check the connections. Okay. ممكن اديكم المحاضره هي معاها كلها لو عايزه المحاضره. لو هم عايزينها مفيش مشكله يعني. طيب خلينا نشوف الكومبليكيشنز. طيب سؤال بقى نسال. Just what kind of complications that the patient of the ventilated patient can suffer? ايه infection you mean? For sure. VAB. This is the very most common complication, the VAB, ventilator associated pneumonia. What else? What about DVT? The ventilated patient cannot move, all the time is on bed. What about pressure ulcer? So all the problems of immobility, the patient can suffer it. But by the way, this is old-fashioned words. Nowadays, in the new guidelines, the ventilated patient can play tennis, by the way. I saw a video, but it's unfortunately, we don't do this, but I saw a video in LinkedIn, if you have an account on LinkedIn. I think it was in Mayo Clinic in America. The ventilated patient is laying with a small football, and he's ventilated, totally ventilated, and he stands like this and playing with the nurse. The nurse is playing with the patient just to support. This is what's called, unlike us, we do the range of motion. If we do the range of motion, if we do the range of motion here, no, they do it actively. The patient can stand, but with a weightlifter. So the patient is supported by a weightlifter and stands like this. They make the patient move, go to stand to see the window, to look to the world. This is the true support for the patient, but unfortunately we don't do this. Not only here, even in Egypt, in all our countries, unfortunately we still don't do this, which I wish one. البولص. نام. انت هتقوم ولا ايه؟ Anyway, So we have here decreased cardiac output. Why we have decreased cardiac output? How does it happen? You know, normally if you have an increased intrathoracic pressure from the ventilation, so the heart will be compressed like this, so it cannot give the power. Yes, so you will have increased intrathoracic pressure, so you may have decreased cardiac output. So barotrauma for sure. Barotrauma means you have like ruptured alveoli. If you give high volume or high pressure, more than the needed for the case, so unfortunately you can get barotrauma. This is very bad complication, and it will lead to pneumothorax and another problems. So ventilator associated pneumonia for sure, as you said, the VAP, and we have a bundle for the VAP. We will talk about it in the nursing care. Complications of tracheal intubation. Tracheal intubation, by the way, we have in the endotracheal tube we have a cuff, and we should inflate the cuff. So let me ask you another question. Seems to be unconnected, but it's totally connected to our topic today. What is the mechanism, or what we can say the pathophysiology of the pressure injury? How it happens, the pressure injury? If we have a patient with pressure injury on the sacrum or the elbow or whatever, what is the mechanism? How does it happen?
Pressure.
Yes, pressure from the bony prominence, and then for sure it leads to decreased blood supply to the area, and then the area will destroy it, and at the end it will turn to necrotic tissue, and it will die, like the tissue will die. It's complete damage for the tissue because of lack of blood supply. So it's the same. We have an inflated cuff at the end of the endotracheal tube. So this inflated cuff, if it's totally inflated, very inflated, more than normal, or even normal but for a long time, it can cause pressure on the trachea, and it will cause necrosis for the tissue, decrease the blood supply. It's the same. So it's the same mechanism. So it can damage the tissue of the trachea around it, and it can cause a very bad problem, which is tracheoesophageal fistula. This is a very bad complication. I saw it once with a patient. It was a cancer patient with prolonged intubation, and unfortunately it has a fistula. We give him like a red drink. I don't know its name in English, in كركديه لو عارفش مش فاكر اسمه ايه. Anyway, it's a red drink. Anyway, we gave him in the nasogastric tube, and we can catch it in the suction from the endotracheal tube suctioning. So it's a very bad problem. There is fistula. Every feeding you will give to the patient, it will go to the lung, which is a very bad problem. So anyway, this is the complications of tracheal intubation. Local airway damage, as we said, laryngeal edema, also from the traumatic movement and like that. Tracheal and nasal and laryngeal inflammation, for sure, also maybe from the traumatic during intubation. Vocal cord paralysis for prolonged intubation. Pulmonary infection, for sure, if you don't handle the endotracheal tube insertion with a good way, aseptic technique like this, you can lead to a very bad infection, and also deep vein thrombosis because of prolonged immobility. Also the pressure ulcer, by the way. There are another things can happen to the patient. Side effects of drugs, like you can give the patient morphine, diazepam, or midazolam. Midazolam, by the way, is a very bad sedative because it's lipid soluble, so it stands in the lipids too long time. So when you even try to stop the sedation, to give the patient the chance to become conscious for what's called sedation vacation, the patient will not become conscious, unfortunately, otherwise after a long time. This is a very bad thing. So unlike the fentanyl, which is short acting, but the midazolam is a little bit long acting because it stands in the lipids. Also complications of suctioning like hypoxia, infection. If you are not managing the suction well, you can cause hypoxia, you can cause infection, and also complications associated with the ventilator malfunction. Yeah, sometimes the ventilator is not working well, like as we will say in the golden rules of ventilation. Maybe you attach the ventilation with a power source which is not good, which is not the right source. We have what's called UBS, uninterrupted power supply, and we have another power supply. The normal power supply, if we have shutdown, electricity shutdown, it will not support the patient with electricity, the ventilator with electricity. If the battery is not good, so you will have shutdown for the ventilator, and it happens once. So it happened once in our ICU, by the way. One of the ventilators, the battery was not good, and it was connected to a supply that is not UBS, not uninterrupted power supply. So unfortunately, it closed. But it's closed. It closed. But we saw it earlier, so we can catch it and manage it. But if nobody was there, the patient will suffer respiratory arrest and will die. Psychological trauma, for sure, this is very important. You know, if you are a normal person and once you just awake on yourself with a tube inside, normally if we are eating and just a small piece of rice just came to the beginning of the pharynx, you start to cough, heavily cough. But this patient has a tube inside the trachea already. It's very bad, but I tried it once because I go to a surgery. I went to surgery before. It's a very bad feeling. Ask me, I tried it. It's very, very bad. And by the way, my colleagues there, it was in the hospital I worked in, so all the OR nurses, they were my colleagues. So they started to play with me. I told them, just remove this. They told me, no, we will not. Keep like this. So it was a very bad feeling, by the way. Anyway, weaning. So we have many criteria for weaning. If you will wean the patient, you should take care that the patient has some criteria that should be there to support weaning, to be sure that the patient after weaning from the ventilator can take his breath alone. So we have oxygenation first. So we should guarantee that the patient has good gas exchange according to our assessment by the ABG. And then ventilator pump function, the work of breathing, the patient can make the effort of breathing. And neuropsychiatric status, this is very important. The patient should have a good neurological status to support the work of breathing, and also a good psychiatric status. This is very important, to be alert, to be to obey your commands when you tell them please breathe, try to cough, like this. And upper airway issues, function of other organs. Let us just go through this. Oxygenation is very important. You should know these numbers. Normally you will do APG for the patient. After extracting the APG, you will check for results just to assess if we have good gas exchange or not. How can you know it? PaO2 should be over 60 if you give FiO2 40 or below. So below 40, FiO2, so this is the percentage of oxygen that you will give for the patient, and you will do the APG. If the PaO2 is above 60, so it's an indicator for good gas exchange, you can wean. So this is the first one. On the same time, if FiO2 is below 40 and the PEEP is 5, not more than 5, this is the PF ratio, it's okay. PF ratio, it means that PaO2 over the FiO2, it will give you more than 200. Let us give you an example. If you give the patient like if the patient is PaO2 80 over FiO2 40%, it means 0.4. 40%, 40 over 100, it means 0.4, right? So 80 over 0.4, it will give you 200 if you count it. So if you have PF ratio more than 200, it's good. So the gas exchange is good. So now PaO2 over 60 if the FiO2 is less than 40 with PEEP 5. If you have this result, it's okay. So you guarantee that you have good gas exchange. You know, it's the same like the indications. You don't have problem with the gas exchange, you don't have problem with the breathing, you don't have problem with the airway, so totally you can wean the patient. Now we have here the ventilation. PaCO2. PaCO2 is this less than 50. Remember the permissive hypercapnia? We have the normal PaCO2, it's from 35 to 45. But you can permit until 50, it's okay, because this is not a normal patient anyway, but not more than 50. So in the ABG, you see the CO2 is less than 50. So this is number one. Respiratory rate is less than 30. It means the patient is not very tachypnic, because if the patient is very tachypnic, so this is a bad sign. So mechanical ventilation less than 10 liter to maintain PCO2. So anyway, now you have about the ventilation. So I mean the ventilation with normal minute ventilation, normal CO2, and the respiratory rate, normal respiratory rate. So this is the ventilation issues. Neuropsychiatric, the patient should be awake, alert, and cooperative. This is very important, because you will tell the patient, please breathe, please try to cough. If he has secretions, you don't have endotracheal tube anymore. You will not go through the endotracheal tube to bring the secretions from inside. So he should have cough reflex. He should be cooperative. You tell him just please cough, and make like the back rubs or the chest physiotherapy, CPT. So upper airway, you should have amount of secretion. I mean the patient can expel secretion, can cough, should have cough. Leak, it means anyway the patient can cough, can expel the secretions out. So anyway, now the patient is cooperative, can cough himself. You should have this. Function of other organs, if you have a severe problem in another organ like the heart, this is a very bad thing. The heart will not pump well, you will not have any enough oxygen, so you will suffer hypoxemia also, it's the same, or hypoxia. So anyway, it's the same, you should have other organs good. So the weaning now, problem with the airway, we don't have problem with the airway. The patient can cough and he's cooperative, alert, he can protect his airway. And then the problem with the breathing, the patient can have effort breathing, and at the end gas exchange, you can measure it with the many parameters of the ABG. 60, more than 60 more than 60 PaO2, the CO2 is not more than 50, while you are giving FiO2 less than 40 and the PEEP5. This is all about the weaning. Nursing consideration. This is the last point today, and this is our care. I will talk about first our role during insertion of endotracheal tube, and then after the endotracheal tube and in the maintenance phase. You should take care of the patient. How can you prevent infection and prevent complications during the ventilation? First of all, during the intubation, our role mainly is just to help to take care of the vital signs. The doctor will concentrate on the airway and inserting the tubes. During this moment, our role is to take care of the patient. He will take care of the airway, we take care of the whole patient. So you should take care of the vital signs, and also the if you will give sedation and prepare the medications for this, induction for the intubation, like the sedation and the muscle relaxant, and like that. Normally in our RCU, we give just fentanyl, midazolam, and recronium, muscle relaxant, and the sedation. So anyway, you will prepare everything and be ready. When the doctor begin, so you will give the induction, and then after that, he will try to think about the airway, you think about the patient to check the vital signs. If you have decreased saturation, heavily decreased, the doctor took a long time, and you will have decrease in the oxygen saturation. So you should stop the doctor, please doctor, just stop, we have 50 saturation, and try to support with oxygen with BMV, the bag mask valve unit, or the PMV unit, bag mask ventilation unit. So you might be asked if the doctor if we have difficult intubation. By the way, we have what's called lemon technique. It's out of our topic, but for more research, if you want to research more, we have what's called lemon technique. Lemon is a mnemonic for look, evaluate, Malampate. Malampate is the name of the scientist, Malampate. And then after that, to check the obstruction, and the N, it's lock, lemon. Anyway, it's an approach. It's out of our talk today, but anyway, this is the way that the doctor will assess the patient if he has difficult intubation or not. So from the beginning, he can know. Unfortunately, not all our physicians do this. I didn't see any one of them just do the proper assessment before. But anyway, some of them. I worked with very, very experienced doctors who can really assess the patient before the The N is the neck stiffness, neck mobility. If the patient has stiff neck or can move the neck with you, like because you will extend like this during intubation. Anyway, you will check the airway for difficulty. After the doctor check, if he has difficulty intubation, he will ask you just to put pressure on the cricoid. You will put the cricoid pressure like here to support division of the airway. Anyway, so at the end, if unable to intubate, this is very important. If you have desaturation, you should stop the doctor. Please, we have desaturation, and bring the BMV and give 100% oxygen just to support the ventilation, the oxygenation. So now we have, this is our role during the insertion of the tube. After that, after intubation, so we should have capnography. Unfortunately, we don't have capnography here with our respiratory therapist, but it's very important just to support if the patient, like to assist the patient all the time, and also it's one of the parameters for weaning, and one of the parameters to be sure that the tube is still inside. So it's important. Anyway, we should have ETCO2. It's a small piece that can connect it to the tube itself, then with a small wire to the ventilator to assess the end-tidal CO2. The normal range of the end-tidal CO2, it's the same like the PaCO2. It's 35 to 45. It's not the same parameter, but it's the same normal range, 35 to 45. Secure the tube for sure. This is the work of the RT, I think, here. The respiratory technician will do this work. But anyway, in other hospitals that we don't have RT, this is our work. So secure the tube, obtain portable chest X-ray. Yes, after the intubation, for sure, you check for X-ray to be sure of placement. And at the end, for sure, these patients will not eat, so we should have nasogastric tube for feeding. This is, as you know, the shape. ETD placement is very important. This is our work every day to assess. If the patient has endotracheal tube, it has a level. 22 centimeters, 24 centimeters, 20 centimeters, like this. So we should assess to be on the lips on the same level every day. It means that you have the same fixation. You fixed it on the same level. If you put it on 22 and next day it was 20, so it's moved already. 24, so it moves. So maybe it's inside, outside, but this is wrong placement anyway. So this is a good way to know, to assess the level, the same level every day during endorsement in the handover process. Normally it's, the average is 22. Males should be like 23, females 21, but let's say the average is 22 on the lips. Cuff pressure, I did not see this device here. It should be with the RT, it's not our responsibility anyway, but I did not see it here. The cuff pressure manometer, it's a small device that assess, as we say, the pressure of the cuff to prevent the tracheoesophageal fistula. So we should have normal range, like here from 25 to 30 centimeter water, or 18 to 25 mmHg. It's different devices. Sometimes we have mmHg or centimeter water. It's the same. Anyway, this is the normal range with here and normal range here. So you should take care. According to the hospital policy and some guidelines, we should deflate the cuff every 2 hours and to assess the cuff pressure. To deflate, just to minimize the pressure on the patient every 2 hours. Unfortunately, as I told you, RT here, they don't do this, but normally we should do it every 2 hours to deflate the cuff and to assess the manometer, and then to inflate with the manometer to the normal range, and then leave it every 2 hours, just to make the trachea rest. It's like the positioning, when you make positioning for the patient, it's the same idea. So also to prevent the tracheoesophageal fistula, if we have prolonged intubation, the doctor for sure will think about tracheostomy. Tracheostomy maybe after 14 days. Not more than 14 days, we will leave the patient on endotracheal tube. VAB for sure, it's by heart. Every day we do it. The VAB, the ventilator-associated pneumonia bundle. This is one of the most important bundles in infection control. So we have a sheet in the Medical Cloud Care system, by the way. So you can do it every day. To make the head of bed like from 35 to 45 degrees, and also the mouth care with chlorhexidine, the DVT prophylaxis by mechanical and chemical prophylaxis, like to give enoxaparin. It's according to the DVT, the thromboembolism, assessment. We have a sheet for DVT assessment, by the way. It should be done by the doctors in the ER, in the emergency department. So the doctor should do it, and according to if the patient high risk or low risk or like that, he will choose the measure to do with this patient, chemical or mechanical. Mechanical is through the foot pump device or the elastic stocking, and also for the chemical it's medication. So DVT prophylaxis, peptic ulcer prophylaxis, this is from the psychological trauma. The ventilator patient all the time has a bad psychological status because the ventilator is very bad, by the way. So most of time we should all the time we should prevent it by giving like controlog, pentazole, like these medications, proton pump inhibitor, PPI, proton pump inhibitors to prevent the peptic ulcer. Daily sedation vacation. Sedation vacation should be done daily in a fixed time. I saw a research before, and unfortunately it was in Israel. Unfortunately it was in one of their universities. They said that the best time for sedation vacation by research it's 6 a.m. because this is the good time for the sedation vacation, because normally we are awake in this time. It's after the dawn. So according to their research, they say that this is the best time every day to make sedation vacation, like 2 hours, for two reasons. Number one is to assess the conscious level of the patient, and then number two is to check for the availability of weaning. So both of them. And then at the end, the subglottic suctioning, doing suction from time to time according to the patient's needs. This is the valve. At the end, the 5 golden rule of ventilation. Number one, set your alarm limits properly. This is the work of the RT. They should have alarm limits because sometimes they make it very high for this patient, and we do the same in the monitor, by the way. Normally we put the monitor, the heart rate like from 60 to 100, but some colleagues make it, we don't want any alarms, and our headache, it's very bad headache, so we make it like 130, and the patient is tachycardic and we don't know anything because the monitor will not give you alarm. This is very bad wrong, very bad work, and we should not do this. And by the way, one of the most important questions from any accreditation, CPAP and the JCI, Canadian accreditation, everything, they will come to ask you about the alarm limits and not to be suspended. Do not suspend the alarm and do not make it with high range. So the alarm limits, proper response and knowledge of ventilator alarms, for sure to know the ventilator alarms as we did already. When there is an alarm, take care. Ventilator is very important. As I told you, it's airway. So as long as you see an alarm, just run to the ventilator to check. Maybe it's disconnected and the patient, yes, to make it off and go. Review the ventilator display to review the type of alarm. If necessary or in doubt, ventilate patient with manual resuscitation. If you are not sure, you see that there is some problem that you don't know what's the problem. We have abnormally, the patient become desaturated abnormally. He was good, and at once he become desaturated. You try to raise the FiO2 and no response, so bring the RT and you can disconnect and use the BMV to be sure that you give the proper oxygenation until the RT come. So now this is the 5 rules, and thank you. We talked about the ventilator and the definition of ventilation. And then we talked about the difference between ventilation and respiration, then the indications for ventilation, and then we talked about the ventilator settings and the modes. After that, we talked about complications, and then weaning with totally all the criteria for weaning, physiological, psychological, everything. And at the end, we talked about the nursing care during, after intubation, and at then the maintenance phase. Any question?
Thank you.
Thank you so much. Thank you.
If you find the ETT, for example, it's released, and you say, for example, it's 24 plus 10, today you find it 24. You will push it again, or you will call the doctor?
Call the RT. Because you can do it, but if you know the technique. But anyway, you should first, if you know that it was 2200% and you know that it should be 22 from the beginning and it's now 24, you can push it. But the problem, not to cause injury, you should not move it while the cuff is inflated. Just deflate and move and inflate again. And then after that, you should listen with the stethoscope to check placement. This is very important because sometimes it goes out the trachea and you put it inside the esophagus. So just take care. When you do it with the right technique or bring the RT.
Another question, it's about the sedation education. Is it a doctor order or protocol?
According to the hospital policy. If we are talking about the scientific lecture, it's according to the hospital policy. But here we don't do it alone. It's according to the patient, to the doctor. But in other hospitals, it's
You will write an order what sedation education?
no. In our hospital, the doctor do it every day in the round. But in other hospitals, in other guidelines, they fixed it. It's fixed because it's a part. By the way, it's a part of the VAB bundle and it's already a protocol, so we do it automatically. But here in this hospital, our doctors, they say no, just wait for me until I come in the round. But I see, it's a protocol. It should be done automatically, but it's okay. You are welcome.